Somebody else like it? Like it feels kind of like risky, and then you get the tube, and you're so proud of yourself, and it's like a great positive feedback loop. And then I get to post-intubation care, and it's kind of a drag, right? It's a little bit complicated. There's all these long checklists, and I mean, maybe, like Arun says, I just need to lower my expectations. But I think, in fact, we could just make it easy. And today, we're just going to talk about the really high-yield things you want to be thinking about in those first few minutes after you've intubated somebody. So here's our case for the morning. This elderly gentleman comes in, severe COPD, still actively smoking, both at home and in your department. Decision is made to put the tube in just to keep the fire hazard risk down a little bit. So you decide you're going to do your typical RSI. For me, I would probably choose ketamine and rock. You drop some drugs, you do a beautiful intubation, you high-five your team. And now you're thinking about post-intubation care. Maybe you have one of those checklists. There are a whole bunch of checklists out there. They look like, all different ones. They are great. They are detailed. But uptake on them has been poor. People don't tend to pull them out. And when I ask informally colleagues why they don't use the checklist that's there on their phone, they say, it's too complicated. Oh, I'm busy. I got to get back to my busy department. I get that. So maybe we can just make it a little bit easier. And I'm going to give you the 4 things I really want you to think about after you've intubated somebody: an A, a B, a C, and a D. Now, A is not your normal A, right? Normally, we use airway, but you've just taken care of that. So here we're going to be looking at, is our patient still awake? We're going to talk breathing, circulation, and then your D is also subtly different. I don't want you to think about disability. I want you to think about the underlying diagnosis, and we're going to talk through these 4 things. Starting with, are they awake? And I will tell you, I have changed my practice in the past few years for how I manage my intubated people, because I'm fairly worried, fairly sure that I was doing it wrong for an extended period. And so let me tell you what I used to do, and then I'll tell you what I do now, and you could think about that. So historically, I would take in my ketamine and my rock, I would do my lovely intubation, and then, I'm looking at the vent, I'm doing my thing, and the nurse would say, what do you want for post-intubation sedation? I would ask for something, and maybe I'd have to put it, in orders. Maybe they would take a verbal. They'd go draw it up. They'd bring it to the bedside. They'd hook it up. And I'd say within 10, 15 minutes, we would be running something in terms of post-intubation analgesia and sedation for that patient. I was always, I wouldn't leave the room without making sure that those orders were in. But realistically, it was probably 10 or 15 minutes until they were actually hanging. And in some cases where we were busy or slower or something got delayed, maybe it was a little longer than that. And the trouble with that is once I did the math on the pharmacology, I got a little worried. Because the key question here is, if you're using, say, ketamine, how long does that last for? When you push it IV, how long are you actually getting dissociative anesthesia? Not just some pain control, but dissociative anesthesia. It's probably lasting 5 to 10 minutes, right? If you're using propofol, about the same. If you go low dose with either of them, it's less, right? In our critical care people, sometimes we lower that dose. So you're only getting good cerebral penetration for a short period of time. And how long is my rocuronium lasting? Yeah, right? Longer. And maybe you're not using rock, maybe you're using Sux. Maybe Sux is going to come back. Maybe in a few years we'll be talking about bringing back succinylcholine. But if it's taking me 15 minutes to get some sedation on board, all of my patients are having a period where they are awake and paralyzed. This, for me, I think is kind of the nightmare, right? When I think about ever having to be intubated myself, that's the one thing I would really like to avoid. I would like excess sedation if any of you ever intubate me. And so this was studied a few years ago, how many of our people are actually aware and paralyzed. There's a scale we can use to measure this. It's called the Bryce scale. And so this is people who remember it. Not just the people who may have had a stretch but were sick enough or hypotensive enough that they don't recall. These were the people who remember being awake and paralyzed. It was about 2.6%. I don't know whether you think that's low or high. If you intubate 38 people in your career, that means you've had at least one. I've intubated way more than that. I've had, I think, based on that math, a lot. A lot. This study was replicated the following year, same group, reproduced it in this next cohort. 3.4% of them had awareness with paralysis. These are ED patients. These are our people who later on remember being paralyzed, right? They looked at what the predictors were. What's driving this? Is there anything in there that's modifiable? One of the biggest independent predictors they found was exposure to rocuronium. When we started using rock, a relatively long-acting agent, we built in this window where our initial induction drugs are wearing off, but the paralytic is still there. Patients can't move, right? You've got them on the vent, you're controlling their ventilation, they can't twitch or yell or do anything else. It's a subtle diagnosis to decide, do they still have some awareness? But this has fundamentally changed how I walk into the room. So now I prepare differently when I'm going to intubate. When I'm asking my nurse for those initial drugs up front, I'm asking for my ketamine and rock for the sake of the argument. I am also asking for post-intubation drugs at that stage. I do like to have some analgesia in there. I go personally with an analgesia first strategy. We know that when we do that, delirium rates are lower in the ICU. If you just go straight benzos or propofol, delirium tends to be a little higher, so it's nice to put some analgesia in there. But it means I am asking for a fentanyl drip up front, or whatever your go-to is. Ask for it when they're getting those initial meds. And I have had the case where it's super busy or things are going really quick, you don't have a lot of time, right? It does take somebody more time to drop a third medication. So in those cases where time is short and I want to keep it super efficient, I just get extra ketamine. Ask for triple your dose. If you were going to give 100, I ask them to drop 300, no extra time, and it means I can give repeated doses in the room until we can get something else on board. It just gives you a buffer of time so that we make sure we're not leaving our patients awake and paralyzed. All right. Once you know they're asleep, because I think we really want them to be asleep, then have a look at your ventilator. I think we all became better friends with vents during COVID, but there are a few core things I look at in the room while I'm standing there right after intubation. Number one's the SAT, right? Peter talked about this a little bit. We don't need a SAT of 100. We don't need hyperoxia. A SAT of 92 to 96 is fine. For this gentleman who had COPD, if you know he's a CO2 retainer, it's okay to take that a little lower. If you're not sure yet, if you haven't had a chance to look the patient up yet, fine, shoot for 92. Shooting at the low end of that range is okay. And I'm just dialing my FiO2 till I get the SAT I want. The thing I'm spending the most time on is their tidal volume. We want low tidal volume ventilation, which means 4 to 8 cc's per kilo. To make this easy, I typically start at 6 cc's per kilo for everybody and then adjust from there. And this is for ideal body weight, right? It's not their actual weight, it's their ideal. So we calculate that based on their gender and their height, right? Because as humans get fatter, your lungs don't get bigger. They just stay that same size we were all meant to be. Okay, and I used to wonder, does it really matter what I set? Like if they're just gonna fix it in the ICU anyway, if I kind of screw it up for a few hours, maybe that's okay. And so, right, let's be practical. You've all been there too, don't judge me. You've all had that thought. And so this was studied last year, a large meta-analysis looking at the impact of setting low tidal volumes in the emergency department. And so they weren't looking at what the ICU set. The ICU could change it to whatever they wanted. They were just looking at how did you do if while you were in the emergency department, you got a tidal volume less than 8 cc's per kilo. Large meta-analysis, about 13,000 people. When they got low tidal volumes, mortality was better. ARDS was lower, fewer days on the vent. The things you dial in matter. No matter what the ICU is doing later, you can have an impact on your patient's mortality by making sure the tidal volumes are low. And so if I've got a 70-kilo guy, say that's our average, if I'm putting in 6 cc's per kilo, that's a tidal volume of 420. Those are the numbers I'm thinking about, tidal volumes in the 300s, 400s. If I've got a tidal volume in the 500s or 600s, I am actually doing that math because I bet it's too high, okay? Keeping those numbers low save lives. The other thing that's proven to save lives is having continuous waveform capnography, having a continuous end tidal trace. One, it tells you the tube's in the right spot. Two, if your patient is boarding for a while and you emerge waiting for their ICU bed, this is the best indicator for when your tube is getting dislodged, right? You can also use it to guide your ventilation. Use the actual quantitative number if you want to adjust how you're ventilating your person. But as a core safety feature, all of our ED patients should have continuous waveform capnography while they're intubated. Okay, so this is what I'm thinking about in terms of breathing. It's only 3 things. The tidal volume takes the most cognitive load, I find, but you can still knock that off within about a minute in the room after you've intubated. And that brings me to circulation. We all know we want to resuscitate before we intubate, right? This is to help people tolerate the physiologic shifts that come along with us putting them on positive pressure ventilation. Because not surprisingly, when we intubate our gentleman with COPD, he has a bit of a slump in his blood pressure. This is in fact predictable enough that we can probably get proactive on this rather than reactive. Like if we know this is going to happen, we can think about how we want to mitigate in advance. Because post or peri-intubation hypotension is getting increasingly studied, and the concern is that it may worsen outcomes. So in the literature, this is defined as having a drop in your systolic to less than 90 within the first half hour after the tube goes in. There is some heterogeneity in the literature there, so there's some debate about what the most effective definition is. But regardless, this is thought to be common, happening regularly in our intubations, and it's associated with worsened mortality and longer ICU stay. It's also associated with peri-intubation cardiac arrest, which we certainly want to avoid. And so taking steps to mitigate that drop in blood pressure can be useful. And so I prep in advance. I walk in with something vasoactive. It could be whatever you like. It could be your push-dose phenyl, maybe you have push-dose epi, maybe you like a norepi drip, maybe you're just grabbing an epi off the crash cart and making a dirty epi drip. I'm not going to judge. But I want something in the room in advance because it just makes sense to me that if my patient is going to drop their blood pressure, I want to minimize that. I don't want a long stretch of them hypoperfusing their organs. That's just going to hurt their nephrons in their brain and all the other things I'm trying to protect. So I walk in the room with my presser. Often this means while my nurse is getting my ketamine, my rocuronium, I'm grabbing the fennel. Or we have pre-stocked push epi in the fridge that our pharmacist makes, and I can just grab one of those. But having something like that set up, your pharmacy department can arrange it for you, so it's a quick grab out of the fridge, makes it so much easier to manage that blood pressure drop as soon as it starts in the room. Okay, diagnosis. This is a different D from what we're normally thinking about. But here's the thing about intubating. In and of itself, intubating does not really fix disease, by and large, with very few exceptions, right? That piece of plastic between your cords does not fix your STEMI and your cardiogenic shock. It doesn't make sepsis better. It doesn't save you from the intracranial catastrophe or whatever's going on in your brain, right? It buys you some time. It buys you oxygen. It reduces your cardiac workload a bit. Like, there are good things here, but it rarely fixes the underlying disease that brought your patient in. And I like to think about this while I'm still in the room because this impacts outcomes. Right there after you've intubated, you want to think about what caused this? What is the diagnosis? If you don't know, no problem. This is your moment to start sending tests to help you figure it out. Fine. But if you do know, this is the time to order all the treatment that's actually going to change your patient's outcome, because there are a whole number of things there that are time sensitive, right? STEMI is time sensitive. So sepsis, so's cardiogenic shock, so's the brain stuff. You want to make sure those things are in first and that they're not left for the next team coming on, because acting on that early makes a difference. So when I'm prepping to walk in now for my intubation, it is structurally different for how I did it 5 years ago. I always want whatever I'm using for induction. Some sort of anesthetic plus a paralytic is what I go with, but I'm taking in the medicine I'm using for post-intubation sedation right up front, and I'm taking something vasoactive in every single time. This helps me mitigate any of the complications right away before my patient can have a critical exposure or outcome to them. So this is the easy approach, the short checklist for post-intubation care. Just 4 things, and let's not leave any of our people awake and paralyzed. That's my personal terror right now, and I think we could all work a little bit to avoid that one.